We're in clinic this afternoon with Dr. Sally Moore and nurse specialist Jackie Green, who are seeing a patient, Mr. Graham Mellis, whose myeloma was originally diagnosed in 2010. At the time of diagnosis, he was offered myeloma 11 trial, but declined to go into the trial. Since then, he's received conventional therapy for myeloma, including an autograft, and for the last 18 months, he's been taking Revdex. The appointment today is because there is now biochemical and clinical evidence of progression, and a further treatment decision is due.
Hello, Graham. Lovely to see you
Hello,
today.
and
Many
you,
thanks for
Sally.
coming.
Jackie,
Hi,
are you
nice to see
keeping
you.
all right? Good, good.
Sorry to keep you waiting, but many thanks for coming. Before we go into the nitty-gritty, can you tell me, how have you been getting on over the last month or two?
Well, not great. Pain's come back, definitely in my bones now, so not feeling too good. Bit more tired, a bit funnily enough, you know, seem to be waking up middle of the night. You know, I'll go to bed really exhausted, but then by 4 in the morning, you know, something sort of clicks me awake. So not sleeping too good either.
So struggling a little bit. And is this similar to symptoms you've had before?
Well, it's not dissimilar to how it was when, you know, we first met, really.
Okay.
So, you know, I know things are moving on. Yeah.
Well, actually, Graham, you're not wrong in that regard. Looking at your blood results that have come through in a little bit in advance, sadly, what the blood results are telling us is that your disease is changing and things are progressing. And as I'm sure, as we've discussed many times in the past, there is inevitability about this, but nonetheless, this is where we are now, and we need to work with it.
So what you're saying is the Revdex just isn't working anymore. Is that right?
Yeah. Yeah. And as I said, this is always going to happen, but what we need to do is actually work on where we can take things from here and how we can make you well again.
Well, I'm assuming that, you know, a couple of my chums in the patient group are on pomalidomide, so my assumption is that that's where we'd be going next.
Have you spoken to any of your friends about that medication, how they've got on with it?
Yes, I know they seem to be tolerating it pretty well, and, you know, things seem to be going well for them.
Okay. Well, pomalidomide certainly is an option. It may be slightly different though from how your friends have received it, and I think we need to have a chat around that today. So we were able to prescribe pomalidomide relatively freely up until a few months ago. And actually we're very fortunate to have access to that medication because in some people it's worked very well, but not in everybody. And as a consequence, we can now no longer prescribe it freely. You can still access it, but that would mean that you'd have to discuss and be involved in a clinical trial. And I know you've had concerns about that.
No, I'm not going down that route, Sally. As you remember, I think you offered me something, myeloma 11, was it? Yeah. A few years ago. I'm not the guinea pig type, I'm afraid.
And may I just explore this a little bit more? Is that your main concern, that we're sort of trialling out new treatments on you, or?
Well, I just want to take you back a bit because, you know, my mates are on pomalidomide. Yeah. And I don't fully understand. I hear what you say about it obviously works better for some than others. But I don't fully understand what you're saying about why that you can't give that to me, you know, straight off the bat now. What's that about?
It's slightly complicated, and I'll do my best, but do interrupt if I don't make sense. So essentially, this is a newer drug that's come onto the market. And as you may be familiar, many of the drugs we use in myeloma are actually rather expensive. And we, as a society, have to weigh up the pros and cons of administering drugs, prescribing drugs, particularly when they come at such a cost. And the government does that. And they do that through a body called NICE, which I'm sure you're familiar with.
Oh, yes, I'm familiar with NICE.
And so NICE eventually, they collect all the information about how well a drug works and how many people, and they decide if it's appropriate for us to prescribe it. And in the case of this drug, we could access this via some special government funding called the Cancer Drugs Fund, but sadly that has now changed, and the government have decided that it's not appropriate for us to prescribe that for many different reasons, partly because it doesn't work in everybody, partly because of the financial implications. And so what...
So, hang on a moment, are you saying, because we know that nothing works for everybody. That's the given, isn't it, in this neck of the woods? So you're saying that I can't have it for financial reasons?
Not solely that, but partly that. It's a cost-benefit sort of analysis which has to take place with every drug that we prescribe. It's disappointing for everybody, and there's no denying that.
So that mean, you know, the chums of mine who are on it will have to come off it, or what?
Oh, interesting. That's not the case, because if you've started it before the funding was removed, as it has been now, they are allowed to continue with it if it's working.
It's a bit frustrating for me.
It's desperately frustrating for both of us. Yeah, and we share that, but sadly this is the environment in which we're working. We've got to work with it.
Because that was the best thing, you know, once the Revdexas stopped functioning, for me, it was the best thing, wasn't it?
It would have been a good option, not necessarily the best thing, because we don't know until we've actually tried with a treatment, but it certainly was an option. But we still have that option available, and this is important for us to explore, but in the context of a clinical trial. And if I can just briefly explain.
I told you, I don't really want to go down the clinical trials route, Sally. You know, we had all this over that myeloma 11, and I just said to you, what I want is the treatment that, you know, not guaranteed to work, but that, you know, is likely to work. I do not want to be a guinea pig.
Well, if I can try and address some of those concerns and those issues. So the first thing to say about this trial in particular is the drugs which are available in the trial have been used on many people with myeloma, hundreds if not thousands of people with myeloma before. Essentially what the trial is enabling the community to do is to collect information on how well particular combinations of drugs work and how long they work for and in which individuals. And so actually it's essentially information gathering. It's not experimenting on particular drugs in your case. So you're not a guinea pig in that regard. It's more of a case of figuring out what happens in the clinical setting when another Graham walks through the door and wants to try these drugs. And that then enables us as a community to put together a case for actually saying, actually, this drug can work very well in these individuals, and therefore maybe we should be able to prescribe it in the future.
I'm sure I entirely follow you. Because, you know, I know with Revdex, for instance, I know, because you told me, that the effect they have together is very different from the effect they have separately.
Absolutely, yeah.
And that the side effects could be very different as well. So effectively, you know, you wouldn't need to be talking about a trial if you knew how they did work together. So whatever drugs you are talking about, we don't know that, you know, just because you know about both of them singly.
You can look at them. You can look at the side effects of any particular drug by itself, or when you add in something else as well. And like you say, with Revdex, we know now, through years of experience on thousands of people, that adding those two drugs together means that they work particularly well, and you know the side effect profile. Whereas this trial is looking at a combination of cyclophosphamide, which you've had before, with pomalidomide, the new drug, and dexamethasone.
So hang on, so there would be some pomalidomide in it?
Absolutely. Sorry if I wasn't clear on that. So yeah, very much so. It's a way of you being able to get hold of pomalidomide, and also a way for us to collect information as to how well it works.
Well, it just seems to me crazy. You know, here's me, you know, desperately needing something now because the Revdex hasn't worked, and you're in the position of having to tell me that I can't have the pomalidomide that you know from what you're saying, it sounds as if you would be putting me on it if you could, but I'd have to have it in combination with other things. I'm not sure about this.
And I think that's entirely reasonable, and many people have the similar concerns.
I mean, what alternatives have you got in terms of, you know, straight up and down treatment at this point?
And that's also a very, very important question. And as you know, as you go through the history with myeloma and your treatments, the treatment options run out. And so in your case, I could think of perhaps one other drug, which I'd be concerned wouldn't work as well as a pomalidomide combination that could be available for you.
And what's that?
A drug called bendamustine, in combination with something called thalidomide and dexamethasone. But what
thalidomide? Ooh, ouch.
Yeah.
Not that I'm thinking of having any children. Neither of us want past that. But thalidomide.
And what we know about this particular combination, which you could theoretically have, is that that also comes with its unique set of side effects. And I would be, to be frank with you, more concerned about the side effects of that combination than I would about being on the clinical
What sort
trial.
of side effects would that give me?
Well, so thalidomide can cause sleepiness, it can cause blood clots, it can cause constipation. The bendamustine component of the trial can weaken your blood counts, and the steroids you're very familiar with.
I know what that does to me, or has done a bit.
I think what's important to say, Graham, is actually our role here is to act as your advocate and to present the options that you have in front of you. And these are, the trial is definitely an option, and I wouldn't wish you to disregard that without finding perhaps a little bit more about it. Because despite your very valid concerns, you might decide when you've looked into it a little bit more, had a chat with Jackie, that's actually something you might want to try, in the knowledge that you can change your mind at any time and it will not affect your care. But that will...
So I could change my mind.
Absolutely.
If I wasn't happy with how things were going on.
Yeah.
But I'm really not convinced, Sally.
No, I know it's...
You know, I hear what you're saying, but, you know, I want tried and tested. But on the other hand, it sounds as if, and there's nothing else beyond this thing with thalidomide that you would say we could give this a go.
Aside from other clinical trials, which sadly we don't have access to here, so that would mean travelling elsewhere to take part in clinical trials, which I don't know, knowing you all these years, whether that would be something you consider.
No. I mean, no way.
Very difficult.
Because especially, you know, driving now has become a bit dicey for me. I wouldn't want to be going further afield, no. Quite aside from, you know, I'm used to you guys. Better the devil you know.
Do you think, would you find it helpful if I was able to reach out to one of our other patients who's engaged in this trial, so that if they were happy and if you wanted to, you could have a discussion with them about it? Would that help ease your concerns?
Well, I won't rule anything out.
Okay.
So yes. I mean, I don't know whether it'd be possible to talk to somebody who's on this other drug as well, with the thalidomide.
Absolutely. Assuming that you know, whoever it is that we reach out to agrees, I'd be quite happy to arrange that for you. No promises though, because it's very much up to them.
I understand.
Yeah. But what would make me feel a little bit happier, Graham, would be if you would just perhaps have a chat with Jackie.
Yeah, I think that would be helpful. If that's okay with you.
Yes, oh, absolutely. Of course I will. Of course I will.
Just to consider this as an option. I don't know if there's anything else you'd like to say, Jackie, at this point in time, just in terms of how other people have got on with the trial, or...
No, I mean, I think it'd be worth us having a conversation, Graham, because I can see that you don't want to be a guinea pig, and I think the pomalidomide is something that we've used very well, and I think it's just get a bit more understanding why it's now a clinical trial.
That's really what I need to get my
guinea pig.
head round.
I think that would be
I
helpful
hear what you
for
say,
you.
but I don't really feel I've, you know, taken it on board 100%.
And it takes time to take these things in. But I must also say that the trials that we have on offer, is a very important point, is that we ethically would not be able to offer those trials unless we felt there was a considerable chance that it was going to work or do you good. We're here as on your behalf rather than
I
looking
know that.
after
I know
anything
that,
else.
Sally.
So, yeah.
I know that.
Okay. Yeah. Have a think about it. Come back to us. Be aware that no question is too big or too small. And you know, importantly, as I've said in clinical trials, if you change your mind, that is no bother whatsoever. We can always then reconsider at that point. But I do think that taking this on board would be the right thing for you.
And so I'll come and have a word with you
Yeah, I think that would really help.
in a day or two then. Because we want to be cracking on, I think, don't we?
I definitely think
Yeah, I
time is
think
of the
so.
essence.
Particularly with the symptoms that you kind of describe, and we know it's kind of how I can remember when you first presented it.
I know, it's frustrating to feel I've come full circle, really.
Yeah. Okay. All right. So if I leave you, Jackie, for a short while, but know you can call me anytime if you've got any concerns as
Of
well.
course. Right.
Okay.
Well,
All
thank,
right.
thank you very much,
My
Sally.
pleasure. Lovely
Okay.
to see you. All right. All right. Lovely to see you.
And you,
Okay.
Sally. All the
Bye-bye.
best.
Thank you. Bye-bye. Thanks.
So Graham, not really the news you were expecting today.
Well, in a kind of a way, it's not unexpected.
Okay.
You know, because having been through round the circle before, I knew that the way I was feeling, you know, Revdex just wasn't working. I'm just lucky it has worked for a little while. yeah, I'm disappointed, but you know, you always hope it's going to be a virus or something, but deep down, no.
You kind of knew.
You kind of knew, exactly.
So Sally kind of put two options on the table, didn't she? The pomalidomide, cyclophosphamide, and the dexamethasone as part of a clinical trial, or considering bendamustine with thalidomide.
Yes.
Should we explore both of those? Would that be helpful?
Well, I don't much like the sound of this thalidomide job, not because it's the word thalidomide, but what she said about actually for some people it doesn't work, and then for a lot of other people they get bad side effects, which, you know, obviously I'd want to talk about those. But yet the alternative, you see, I go back to, I know she says that, you know, I wouldn't be a guinea pig, but, you know, it wouldn't be a trial, would it? Unless, if you knew about how these drugs work together, you wouldn't need to do a trial, would you?
Yeah, so I think we know we've got enough evidence that the pomalidomide works. We know that it works very well. So from that point of view, being guinea pig with that particular drug isn't really on the table. The reason that it's come off license, we can't give it, is because of the risks and the benefits of it. So we haven't got enough data.
Well, I mean, no, but I mean, let's be honest. From what Sally was saying, it sounds as if it's financial reasons more than anything.
So I think, as Sally said, it is partly financial reasons, because the cost of it, in line with what the evidence are from the long-term benefits, is why the cost does come into it. But in terms of the evidence base for whether the drug works, I think it's very clear from all of us that we know that pomalidomide works very well for myeloma.
See, that's my frustration. That, you know, had I been around in the same position a year ago, I'd have got the pomalidomide without any problem. But now there's been this cut-off point from what you're saying.
Yeah, that's absolutely true. Absolutely true. And I share that frustration.
And there's no way we can plead special cases or anything like that.
I don't think we can. We've looked at that before, and that isn't really an option now. The only way for us to get the pomalidomide is the clinical trials. So I think we kind of need to explore. Because I really get you. I remember having a conversation with you back in 2010 about your anxiety and guinea pig.
Exactly.
So being a guinea pig is obviously one of your biggest concerns. Have you got any other concerns around clinical trials?
Well, no, I trust both of you, you know, with my life, literally. And so therefore I've not any doubt what Sally says about, you know, we wouldn't be offering this unless we thought that it had a good chance of doing something for me.
Yes.
I accept that. But I also know about trials that quite often because the way they're fixed is you don't necessarily all get the drug, do you?
So this is a trial that's looking at, so the drug is there, but it's looking at pomalidomide dex versus pomalidomide cyclophosphamide and dexamethasone. So the drug is in part of that
So
trial.
hang on, so you're trying two different trials at the same time? Right. But whichever...
It's looking at the combination
Right,
of therapies
I'm with
using
you.
that particular drug.
So there won't be some people that aren't getting anything at all or anything like that? None of that?
No. Was that one of your concerns as well?
Well, it would have been,
Yeah.
you know, that I might have been on, you know, nothing at all, which
No,
obviously...
that's not what this trial is about. I mean, as Sally and I both said, you know, we need to treat the myeloma again. So absolutely, no, it's not, this particular trial isn't looking at that. Although you're right, some do look at that, look at the placebo effect.
So would I, or at any rate you and Sally, be able to choose for me, even though you might think one was better than the other for me?
No, because the clinical trial access is around using the pomalidomide. What we're looking at is the combination. So you either get randomised into pomalidomide and dexamethasone, and you've had that steroid before, or we give the pomalidomide dexamethasone, add in a third drug, which is the cyclophosphamide. And again, you've had that drug before.
So there's nothing apart from the pomalidomide that I haven't had before.
Absolutely.
But you can't choose which of the two
No,
sets.
and that's the clinical trial in essence. Is about which arm you go into.
Do you think there's any difference between the two? What's your gut feeling about it?
I don't know the answer to that, because that is why we're doing the trial in combination. There is a school of thought that would absolutely say the more drug combination you've got, so 3 drugs together will be better than 2 drugs. There's enough evidence to say that the dexamethasone and pomalidomide works very well.
Right.
So there isn't really that's part of the clinical trial. That's what we're
Okay.
trying to find out in essence.
So,
really.
I mean, you know, if it were you, Jackie, perish the thought, would you go on this trial if you were in my situation?
I would. But that's my personal choice. I'm not you, Graham.
No, I know,
Yeah?
I know. But I
This-
asked you
this
the,
is your-
question.
This
I
is
wanted
your
to know.
choice.
And would you go on that rather than this alternative with the thalidomide in it that Sally's talked about?
I would. And the reason for that is that the bendamustine and the thalidomide would be another arm of therapy that I could have later in the line. But as I said, this is me, and with all my background, and I'm not adverse to clinical trials, and I haven't got the anxiety that you have, Graham, with them. No. So this is your decision, and we will support whatever decision you make.
So just let me get that straight. You know, things take a bit of a while to sink in, but what you're saying is that if I go on this trial,
Yeah.
that leaves this other combination as a kind of ace in the hole should we need it.
Potentially.
For
Obviously
later on.
depends on how you are and
Yeah.
where we're at, but yes, potentially.
In terms of the trial, I would be having it here, would I?
Yes. We have the trial open here.
And in terms of, you know, how regular I come in, would that be the same as it has been?
It will be actually, yeah. You've been
Right.
coming out every month.
Every
haven't
month?
You know, yeah. So,
Exactly. So that would be the
Yeah.
same. How many people are on this trial? This is where I come back to not wanting to be, you know, me and 10 others. You know, is this a lot of people on it?
There will be a lot of people recruited. There's a number that we are looking at that nationally they're trying to recruit into. So there will be a large number. It's not just a handful of people.
handful of guinea
No, and it's not just our hospital that's that. So there's many hospitals across the country that have got these trials open.
Because it sounds more tempting to me than the myeloma 11 was, but, you know, partly because I'm that much further down the line now. And,
Of course.
you know, my options I can already start to see, especially with the, you know, the frustration of the pomalidomide not
I know.
being available to me. But that's the luck of the draw. You know, there's no good blaming anybody for that. I'll tell you what I'd like to do. I'd like to talk to my wife, to Pat, about it. And then, how long before I need to get back to you with my decision?
Well, I think as we said earlier on, we would rather get started on some treatment sooner rather than later, and it's all about managing those symptoms and not letting it progress.
or tomorrow.
I think you could have.
Give you a call.
Yep, you can give us a call in today or tomorrow. You come back and see us next week when we can have that conversation again. I know that Sally just asked you about whether you would like to speak to anybody that's actually on the trial. We can, with those people's permission, we could see
I mean,
them out.
to be honest, I've spoken to you about it. I feel I'm a lot clearer now
Yeah.
about, you know, and I have been on all these drugs, as you've now clearly pointed out.
Of course.
Although not in this combination. So I kind of know the score as far as they're concerned. Have you got any leaflet or anything that I could show to Pat about
On the
this?
clinical trial
on the clinical
itself,
trial?
of course, yeah, there's some patient information on that clinical trial itself, which I can give you today that you can go away and read it through with Pat. And maybe let us meet Pat in clinic if she was up to it. We can always answer questions for her.
Well, I think you know the answer to that.
I know that. Worth a try.
Worth a try, you know. Close but no cigar.
Absolutely.
Okay, right. Well, if you could let me have that,
Yeah,
and then I'll give you a call. Well, you know me. I won't leave you hanging around.
No.
I don't want to be hanging around myself.
Yeah, so I mean, maybe the thing to do is to give you some information about that clinical trial. You go away, take it away with you, have a conversation with who, you know, with Pat, with anybody. Write down all the questions you've got that are related to the trial, or questions that you might have around it. And then if you give me a call, then I can arrange for you to come in and we can have a conversation, and then make a decision from there. Would that sound sensible?
Right, Jackie. That sounds very sensible. Okay, well, that's what we'll do then.
Is there anything you want to ask me immediately?
Not really. Just need it to let it sink
Yeah,
in, really.
no, it's a lot of information to take in today, isn't it?
No, but you made it easy for me.
Okay.
Thank you for that.
I've asked Sally to rejoin us in the consultation room so that we can review how this discussion went. Graham, a difficult time in the course of your disease, difficult decisions that you're facing, but you're here in clinic with two people that you know very, very well and clearly trust implicitly about the management of your illness. And it still turned out to be a very difficult conversation.
Yes. Well, I wasn't expecting, first of all, that I wouldn't be able to have the pomalidomide. I do understand the reasons.
And that's obviously circumstances beyond the control.
Circumstances
of-
beyond
of
Sally's
Jackie.
control and Jackie's control. And therefore, I wasn't expecting that I'd, be put back to, where I was at square one, being asked whether I'd be interested to go on one of these trials. And having been dead set against it back then, my first inclination was to just dig my heels in.
Yeah.
Especially as I couldn't really understand how I could have the pomalidomide in these trials that Sally was telling me about, but not, just on its own. So that was one of the difficulties I had.
You've had very definite views about the treatment choices all the way through, haven't you? My memory is that you weren't keen to have thalidomide right at the beginning when
Yes.
the trial was initially
Yeah,
offered
I
to
was,
you.
I was really surprised when that came up, because we know the history of thalidomide, and I was against it then, and I'm really against it now. And from what Sally said, it sounds as if she rather thinks that's second best treatment anyway, compared with the trial. And because I trust her so much, as I trust Jackie, my feeling talking to Sally was that, she looked me in the face and she said, I wouldn't be offering you this unless I thought it would do you some good. And really that for me was the crucial moment in at least opening my mind up to the idea, because before that I thought, no, I'm not having a trial. But when she looked at me like that, I can't deny her that, because I know that she wouldn't, as I said to you, you wouldn't pull the wool over my eyes.
So Sally, you're faced with somebody with an antipathy to going into a clinical trial, perhaps founded in real things, perhaps founded in his own interpretation of things. How do you persuade somebody in that situation that the best thing for them is an option that involves a clinical trial?
I think I would say one of the most important things, and knowing somebody for so long as I do know Graham, have known him such a long time now, is actually understanding that individual, and actually knowing that his concerns are very valid, and they're there for very good reason, and to acknowledge that. But equally, my role is, as I said, really, to act as his advocate and present choices. And therefore, presenting the choices in a rational way can often be challenging. And this consultation was very illuminating, but again, it is challenging, trying to explore a very complicated area in depth within the short period of time we have in clinic. Yeah. But I think to sow the seed of an option, which is essentially what we're dealing with, so that he can then make an informed decision. That's what I hope to achieve throughout these meetings.
Well, I thought we watched you do that extremely well, and I thought we watched you do it very, bringing a lot of empathy into the discussion and identifying quite explicitly with the difficulties that Graham's facing over the decision. Jackie, Graham asked you what I think a lot of healthcare professionals view as the very unfair question: what would you do if it was you?
So, well, actually, I don't think it's an unfair question, because if I was in that position, that's exactly what I'd be asking. But actually, as the healthcare professional, I find it's that quick decision you have to make about whether you are going to be able to share what you would actually do in that situation, and how relevant that is. And I think for me, it's about making sure Graham understood that although that might be my choice, I respect the fact that it isn't necessarily his choice, and he still has a choice. Just because I would agree, I would go on a clinical
But it
trial.
remains very powerful advocacy for the option, doesn't it? To hear somebody who Graham clearly trusts as much as he does you to say, if it were me, I would do it.
And I think that was the crux of it. I think that we've known Graham for a long time, so I know that it would be important for Graham to understand what I would do as a healthcare professional, so that that trust and that faith, and he'd know I wasn't saying it just to persuade him. He'd know that we had that relationship where he could ask me that question and I could speak openly about it.
And when she answered, she put her hands on the table over yours.
Yes. She's always been like that with me. It's lovely, actually. It's as if, she was my daughter or something. It's that easy talking to Jackie. It always is. what was great for me in our conversation was the fact that what at the back of my mind was, is this trial going to mean that I might get something or I might get nothing at all? And you were really clear with me that that wasn't the case.
That ghost was firmly laid, wasn't
Absolutely.
it? Put out
So,
of the-
you know, I feel I'm in a position, especially as you're going to give me the leaflet, to go back and say to Pat, this is the option. It's clear from what both of them said that they think this is a better option than the alternative. Because the other thing Jackie really got home to me, and Sally too, thinking back on it, was it doesn't rule that other option out.
Yeah.
That is still in there, if you like, as a backstop for, you know, for further down the line when we get there, as we will. So why use that now when there is this other option? Seems to me a really powerful argument, especially as I'm getting something. There's no way I'm getting nothing.
So it seems to me that the key question, and I'm pretty sure I know the answer to this, is do you feel that you were put under any undue pressure to go into this trial?
No, I don't think I was, you know, there was no emotional pressures on me from either of you girls, really.
The options were fairly laid
The options were fairly laid out, and it seems to me very logical. It was more my emotions that were probably the difficulty, and sort of because my initial thought was, oh, no, no, no. But, you know, with all the logical stuff that I've been given by both of you, and I feel from both of you that you're talking about me. It seems tailored to me. It's not a general thing, oh yeah, we want to be doing this to find out more. It's about me at root.
Yeah,
And I think that's what makes the difference.
There is not another trial candidate just waiting to come in and have the same chat.
No, exactly.
Indeed. Good. Graham, thank you very much. Sally, Jackie, thank you.